is introduce the moderator of the next panel, our lead senior editor on the book, and she's also foundation professor in clinical psychology in the Department of Psychology at the University of Nevada, Reno. So this is Victoria Follett. Please honor and welcome her along with me.
Well, I am indeed honored to be here. It's a very powerful experience to sit in the room with people on the same path. And I look forward to hearing the rest of the talks. I'm going to go rewrite my talk because John just gave mine. That or we could make it really short and I'll say ditto. But my job here is lovely. It's easy. I'm going to introduce our speakers. There was a request that we give a little context. Rather than jump up and down, I'm going to just give a brief overview of all of them. And they're all wonderful. Oh, that's more than that. Dr. Chris Germer is a clinical psychologist in private practice, specializing in mindfulness and compassion-based therapy. He's been practicing these principles and introduced meditation long before it was popular into therapy, and he is a founding member of the Institute for Meditation and Psychotherapy and a clinical instructor of psychology at Harvard Medical School. We'll also be hearing from Tony King, who spoke last night. He's a professor of psychiatry research at the University of Michigan Medical School and a faculty associate for social research and trauma and stress.
That's good.
This is Dr. Germer. I have the cheat sheets here, so it's great. Jenny Phillips I love the diversity of this, and I've heard her speak. She's amazing. A cultural anthropologist and filmmaker and writer and a psychiatric nurse. She practices and incorporates all of this into her work with crisis intervention. And finally, although these weren't said in order, Dr. Ron Siegel, and he is an assistant professor of psychology part-time at Harvard Medical School, and he is a longtime student of meditation and serves on the board and is a faculty of the Institute for Meditation and Psychotherapy. So I think, as last night, we'll hold questions and discussions until the end. Dr. Briere will be moderating those discussions. And it's my great pleasure to introduce Dr. Germer.
Thank you. Thank you, Victoria. Oh, this is unlike Grand Rounds, isn't it? Anyhow, I'm thrilled to be here, and I so enjoyed John's fabulous talk. And John also did share that we have 18 minutes, each of us, to speak, so this will be fun. So my topic is cultivating self-compassion in trauma survivors. So perhaps we should start by asking the question, what is self-compassion? So self-compassion is really treating ourselves as we would like others, our friends and our family, to treat us, particularly when we suffer, when we fail, and when we feel inadequate. How often do we do that? What happens, actually, this is a question to everybody, what happens when things go wrong in your life, when you feel inadequate, when you suffer and fail? What is your own reaction? What starts happening inside of you? Self-blame. Self-denigrating. Shame. Judgment. Guilt. What? Blame your wife. Blame your wife, exactly. What did you say, pet the dog? Yeah. Kick the dog. Not really. Kick the dog, yeah, I understand. Okay, what are some others? Constriction, yeah, we start to narrow our perception a little bit out of fear. What else? Anxiety. Anger.
The blame one is really, I find myself doing that too. I start to find fault in others.
Yeah, we criticize ourselves and we criticize others. Drinking, yeah, we start to try to numb ourselves. We don't want to be in our own skin, you know. So we say that there's an unholy trinity of reactions that occur when things go wrong in our lives. And this happens to actually most of us. The first is self-criticism. The second is self-isolation. In other words, out of shame or just discomfort, we don't want to be in our bodies. We'll distract ourselves, drink, dissociate. And self-absorption, we ruminate. Our field of awareness shrinks. We get stuck in our head, you know. So this makes a lot of sense because when we feel under threat, we have the fight, flight, freeze response. And fight is good for an external danger, but when the danger is internal, then we go into self-criticism. Flight, self-isolation, freeze, self-absorption. We get kind of stuck in our heads. And it's interesting that these three categories do correspond to the clusters, symptom clusters in trauma. So for example, the fight response or self-criticism is close to arousal. The self-isolation response is close to avoidance, and the self-absorption response can be related to intrusions. Now, what's interesting is self-compassion, at least as defined by Kristin Neff in 2003, is precisely the opposite. Instead of self-criticism, we have self-kindness. Instead of self-isolation, we have common humanity. In other words, I'm only human. We actually feel we're a part of the fabric of suffering in life. And instead of self-absorption, we have mindfulness, not a constricted field of awareness, but an open field of awareness. So there are now over 400 articles in the psychological literature on self-compassion, and about half of them have come out in the last year and a half. So this is a hugely burgeoning literature. The research began in 2003 when Kristin Neff published her scale, the self-compassion scale. Mark Leary, a psychologist, neuropsychologist as well at Duke, said that the research in self-compassion is now getting boring. He said because just about every measure of emotional well-being is associated with self-compassion. So we find consistently that self-compassion is associated with decreased anxiety, decreased depression, less stress, rumination, thought suppression, less shame, less perfectionism. And it's associated with an enormous range of positive factors such as life satisfaction, satisfaction in relationships, autonomy, self-confidence, wisdom, happiness, optimism, creativity, conscientiousness, ability to apologize, health behaviors, less drinking, less smoking. So you can imagine how this works, you know. In other words, if you care about yourself, if you're kind to yourself, if you treat yourself as you would like your loved ones to treat you, you will do the right thing by yourself. You'll go to the doctor when you're sick. You won't be so afraid of it, you know. Things like that. So another question, since John was just speaking so much about mindfulness, is what is the relationship of self-compassion to mindfulness? This is kind of an important question. But the answer for each of us depends kind of on who we are. In 1857, Charles Darwin spoke about lumpers and splitters. So in the mindfulness universe, lumpers are those people who say, well, we don't really need to talk about self-compassion or compassion in general. It's already in mindfulness. If you're mindful, you're compassionate. Why do we even have to bring up another word? Those are lumpers. Any lumpers in this room? You don't have to reveal yourself. And then there are splitters. Splitters say, well, there's a reason we have a word mindfulness, we have a word compassion, self-compassion. Why do we have these words? Well, we have them because they're different. Those are splitters. Scientists are often splitters because they need to precisely measure certain precise things, you know. So we can say that it's all in mindfulness, it's all in compassion, or we can say they're different. However, in my view, when mindfulness or compassion are fully present in our lives, fully present, the other one is also present. So in that case, we could say that self-compassion is the heart of mindfulness when we suffer. It's the heart of mindfulness. It's the beating heart of mindfulness when we suffer, as John Peacock may say. But our mindfulness is often partial. It's tinged with desire, it's tinged with confusion, it's tinged with fear. And then it's good to know what are the differences. So just by way of describing differences for those splitters amongst us, or those practitioners who would like to occasionally add a little something, these are some of the differences. And that is that mindfulness, as we know it, is about acceptance, as John said, but particularly acceptance of moment-to-moment experience, this thought, this feeling, and so forth. Compassion is about, particularly self-compassion, is about accepting the experiencer, that fictitious self, that one that John was saying, you know, there's actually a Dalai Lama and a Jack Cornfield that's identifiable, you know. So that, you know, the experiencer, when we have compassion for the experiencer or the I, that's compassion. There's like, it's an object, it's relational. It's self to self or self to other. The other thing is that similarly, mindfulness asks the question, what am I experiencing right now? So when someone comes into your office, they're suffering, you want to know what they're going through, what they're feeling. What am I experiencing right now? Compassion asks, what do I need right now? Right? What do I need right now? A slightly different question, isn't it? Complementary, and they support one another. Mindfulness says, feel your suffering with spacious awareness. Can you make room for it? Can you make space for it? When we suffer, can you make space for it? Can you be with it? Compassion asks, or self-compassion, be kind to yourself when you suffer. Hold yourself in a loving embrace. You know, this is this nasty little self thing that we're focusing on. But what we're discovering is that when you focus on the self when you suffer, it actually dissolves the self. It is a paradox. So what does all this have to do with childhood and adult trauma? So in adult trauma, self-compassion is a powerful mitigating force for self-compassion. There's a new study that just came out at was just finished, a dissertation study at the University of Texas. It's going to be published shortly, with vets from Iraq and Afghanistan. And the author found that vets who were higher in self-compassion were lower on avoidance of their internal experience, and hence had lower PTSD. And what was particularly interesting is that PTSD, that self-compassion was a stronger predictor of whether somebody got PTSD than the severity of combat experience. So you could have seen or experienced or done terrible things, but if you have a lot of self-compassion, you're less likely to develop post-traumatic stress disorder. So what is this like? What does this mean? So if you're a vet, well, there are two elements. One is the non-avoidance of difficult internal experience, but the other is, if self-compassion is nothing else, it's an antidote to shame. And shame is so much a part of trauma. So if you're a traumatized vet, inevitably you've done terrible things, you've seen terrible things, people who you admired have done terrible things, and you come back and you're shaking with this. Your worldview is shattered. So if you have a lot of self-compassion, how does that work? Well, first there's the mindfulness element, which is, I'm suffering. I'm in pain. This really, really hurts. A catastrophe has occurred to me. In other words, this is a way of just moment-to-moment reckoning. This is terrible. The second thing a traumatized vet would say is, that was war. And in war, people do really bad things. I did really bad things. I've seen really bad things. That's war. In other words, common humanity. I'm not the only person who does bad things. You know, this is the dependent arising thing that John was talking about. And then finally, self-kindness. Self-kindness. And that is an attitude of, you know, I'm going to do whatever it takes to heal my mind and to heal my heart. I'm going to do whatever it takes. I must be kind to myself. I must make myself whole again. This is completely different than a shame response. This is completely different from self-criticism, self-isolation, and self-absorption. It's a motivator. So what about childhood trauma? So that's a lot trickier than adult trauma because of insecure attachment. So why do people with childhood trauma have insecure attachment? It's because as children, naturally, they've gone to primary caregivers in order to be comforted and soothed and consoled, and then they've been hurt. So it creates an approach avoidance situation. And this, when we start to practice compassion or even to receive compassion, it becomes dangerous. In other words, you get the same feeling, the preliminary feeling of comfort, the sense of safeness, and with safeness arises the memory of pain. So that leads to what Paul Gilbert brilliantly talks about, the eminent psychologist in the UK, as fear of compassion. So this is really important. We see this all the time as therapists. When we give compassion to our clients, sometimes they regress. Fear of compassion. So let's do a little experiment together. I'd like everybody, please, to put your hands like this and put them over your heart. And just close your eyes. And just notice how your body feels since you have done that, how it feels actually right now. And please, out loud, sort of popcorn style, just describe emotions that are in your body with your hands in this gesture. Just say out loud. Warm. Warm. Tender. Mm-hmm. 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 Ah. Nurtured. Loved. Peaceful. Blessed. Safe, slower. Okay, so thank you so much. You can open your eyes. Now just imagine if you were traumatized. If you were traumatized and you put your hand over your heart like this, what you would feel then? What if as a child you were told you were garbage and that you shouldn't feel good and that you don't deserve to be comforted? We know many people like this. What would happen when you put your hands over your heart? Okay, so this is, it's very difficult for traumatized people often to do this. So I had a patient who was severely traumatized throughout his childhood, and particularly when he was happy. His drug-addicted mother couldn't stand to see him smile. So he learned that feeling good was a punishable act. And so I asked him once, I asked him at some point, how do you comfort and soothe yourself? And he says, well, I don't dare. I said, do you ever feel good? He said, yeah, when I pet my dog, I feel good. He said, however, when I notice that I'm starting to feel good, then I get frightened and I have to stop petting my dog. I cannot continue petting my dog. He said, but this is a problem because I really love my dog and I want to be there for my dog, and my dog needs petting, of course, but I can't do it because I'm so terrified when I recognize that I'm feeling good. So then he had the idea, actually, you know what I ought to do? I ought to just see if I can, feel anxious a little longer while I pet the dog. In other words, allow the pain to flow through me, as John was talking about, like urge serving, or sort of just tolerating pain. So he was able to do this. After about 2 months, he was just thrilled. He told me, I can pet my dog for 3 minutes, So he was exposing himself in this way. So often in the treatment of trauma, the way people find a way to themselves is by accessing first how they feel toward particular loved ones, especially innocent loved ones like pets and children and so forth. I have another patient who had a beautiful golden retriever, and she herself, she was quite poor, and she literally was starving herself because she only basically bought food for the dog. Her hair was falling out and so forth. And then I taught her some loving kindness for her dog, May Ginger be safe. May Ginger be healthy. May Ginger live with ease. And she did this for a long, long time. And then I said, are you able to perhaps add yourself? Because if you are not well, your dog can't be well. Your dog needs you. Okay, may Ginger and I be safe. May Ginger and I be healthy. May Ginger and I live with ease. Yeah. And then at some point, may we. And then one day she came in to see me with tears in her eyes. And she said, I can do this for myself. I can do this for myself. So this is an extraordinary achievement, First we love others, and then we tuck ourselves in. So How much time do I have, by the way? 2 minutes. Oh, weren't you going to flash something? Okay. Okay, well, just let me say this, that when we practice loving kindness, there are 3 reactions. We can feel good, bad, or nothing. And the reason why we feel bad is because we can only know anything by contrast. So there's a saying, love reveals everything unlike itself. Or the way, when we give ourselves unconditional love, we discover the conditions under which we were unloved. And so this is called backdraft. In other words, just like in firefighting, you open the door of a hot room, the fire comes out, you know. All our hearts are hot with suffering. When we open the door of our hearts and the love goes in, pain comes out. So this often feels like a kaboom, but what I say is this is a kabloom. This is a kabloom. So compassion, okay, this is how it works. We shouldn't be afraid of this. This is how it works, right? So compassion opens us to our suffering, but it also heals the suffering. It's an extraordinary resource. How do we teach it? We teach it through relationship and psychotherapy, through affective attunement. We're always training one another's brains in our brain state. When we're in a happy mood, we train other people in being in a happy mood. We can also teach people through exercises and techniques and practices. So, for example, asking the question, what do you need? And often you can teach people skills to comfort and soothe the physical body. This is really important for trauma people. And you can teach people how to motivate themselves with encouragement rather than criticism. These are 2 general categories of practices. Men like the latter one more than the former one. I'd like to say that at the end of the day, self-compassion training is really about warming up the conversation. It's about warming up the conversation. It's not changing anything. It's not manipulating anything. It's about warming up the conversation. And it's not even about learning self-compassion. We say we don't teach self-compassion. We don't learn self-compassion. We just learn to embrace our imperfections. Imagine that. And this is a good thing just for about all of us, but especially for trauma survivors. Thank you very much.
I'm delighted to see it is possible to say something meaningful in 18 minutes. Many other people have done it before me. I'm hoping to be able to do it myself. Do we have, yeah, we got it. Okay. So let me start my stopwatch here. So what I thought I'd do in the next 18 minutes is outline some of the mechanisms by which trauma can cause chronic pain. And here I mean chronic physical pain and actually a whole host of psychophysiological or stress-related disorders. And then, depending on time, a little bit about how mindfulness practice can help us with this, although I think it'll be pretty obvious when we look at the mechanisms by which this occurs. Now, for both our clients or patients, as well as most healthcare providers, the idea that trauma might be, and here I mean emotional trauma, might be the cause of chronic physical pain seems a little bit odd, because after all, we all have the experience that physical pain is associated with illness or injury. We cut our finger, we see blood, we feel physical pain. But as it turns out, a major risk factor for a wide range of chronic physical pain disorders is basically a high ACE score, a number of different adverse childhood events. And this predicts things like lower back pain, chronic pelvic pain, self-reported arthritis, chronic orofacial pain, fibromyalgia, chronic headaches, basically the stuff that fills a lot of primary care offices. Many, many of these disorders are predicted by having these childhood traumatic experiences. So how could this possibly be? Well, it's clear how people think of this as structural. For example, we'll use chronic back pain as an example. If you go into the orthopedist's office, you're told, well, your back is a series of vertebrae. They're separated by cushioning discs. The discs are like jelly donuts. They have a firm outer part, a squishy inner part. You've had wear and tear. The squishy inner part bulges out, presses on nerves. No wonder we have such an epidemic of chronic back pain. You better be careful. And I can tell you, because I got into this as a patient myself, there's nothing quite like being told that your spine is a series of bones separated by jelly donuts to give you faith in it. You know, a real sense that this is a robust structure that can see you through life. We're also typically told the orthopedic story, which is the reason why we have so many problems is we evolved originally to walk on all fours. We became Homo habilis. We started using tools. Now we have ergonomically unwise workstations. So that's why we have this evolutionary accident. And I'd propose there's another evolutionary accident afoot, and it's actually the pairing of our fight-or-flight system, which has been so useful for helping us through so many different kinds of difficulties in terms of our evolutionary history, and our capacity to think. And you put these two together, and it's something of a recipe for disaster. The way in which it's made worse by trauma is really by four major processes, and I'll walk you through these. The first is we have higher autonomic reactivity when we've been through trauma. Study after study shows this. It's basically if you're walking in a neighborhood and it looks scary and it's a neighborhood where you know there's a lot of crime and you hear rustling in the bushes, we react with a lot of autonomic reactivity. If we're walking through a safe neighborhood, the same thing happens, rustling in the bushes, figure it's probably a cat, I'm fine, very little reactivity. People who've been through trauma see everything as a dangerous neighborhood. It also predisposes us to illness anxiety, which we'll talk about shortly, which is when faced with ambiguous stimuli, and the body is always producing ambiguous stimuli, if everything's a dangerous neighborhood, these ambiguous stimuli become dangerous. It becomes much more likely we're going to focus on them in a fearful way. Our ability to self-soothe, what Chris has been talking about in terms of self-compassion, is seriously diminished when we live in a very dangerous neighborhood and when we see our whole world as dangerous that way. And then finally, what John was talking about, that there are so many contents that we push out of awareness, and there's all this cultural support for pushing those out of content, those things out of awareness, that when we're doing that, we are constantly threatened by those contents, and this constant threat creates another kind of arousal. So how might arousal turn into chronic pain? Well, let's look at how it works with back pain. And let's say it starts in the upper right-hand corner from, is this a pointer? Yes, it is. From injury or soreness connected with some activity. Let's say we live in New England. You've probably never heard of this in Southern California, but this white stuff happens around December, and we start to do this motion, and we're not accustomed to that. And our back hurts, so we get a sensation of back pain. If we're so unfortunate as to live in a culture that has an already epidemic condition of chronic back pain, then we have negative thoughts about this. We think, oh gosh, the back is a vulnerable structure. Even if we haven't heard the jelly donut story, we have a sense that, well, I have a friend, patients, relatives who have been stricken by this. I hope I didn't do something serious. Those negative thoughts lead to certain negative emotions. And if you wouldn't mind joining me in this, it'll help to illustrate it. And you have to join me. If you leave me alone with this, it's going to recapitulate a serious junior high trauma, and it would be cruel. And I know you're really nice people, so you'll join me. When I say 3, I want you to show me with like full acting enthusiasm what fear looks like, okay? In the body, we're here alone, it's a Saturday, don't worry. Ready? Listen up. 1, 2, 3. Thank you. Don't leave me alone with this. This is important. It was really bad what happened. We don't have to go into details, but we don't want to do it again. Okay. Now when I say 3, give me anger. What real rage looks like. 1, 2, 3. Excellent. Now we'll do a little more subtle. We'll do frustration together. 1, 2, 3. And finally, some mixture of anger, fear, frustration, where you really don't want to show it. It wouldn't be socially appropriate. You're seeing your in-laws, or you're visiting with a doctor who you're heavily dependent on but hasn't helped you with your pain yet. Ready? 1, 2, 3. Excellent. Now, what was happening in your body, your skeletal muscles in particular, in all of those conditions?
Tension.
Tense. So we have these negative emotions are associated with tension, right? Well, tense muscles hurt, right? You ever have these muscles tighten up, or ever get a Charlie horse in your calf? Hurts a lot. So the pain increments up. So we think, oh my God, I really have damaged myself this time. Almost immediately, we start to restrict physical activity. We think, I don't want to injure myself further. I better stop exercising. I better stop going to my yoga class. I better stop doing the things I do to take care of myself. We in some way restrict our normal activity. That leads to all sorts of deconditioning and vulnerability. And this cycle just keeps going. And I've seen people in this kind of cycle for a month, a year, a decade. I have 2 patients who were in it for 40 years. With their lives just totally disabled by this stuff until they saw what they were doing and were able to walk out of it. So how does a trauma history predispose us to this sort of difficulty? Well, since most of you are meditators, you know that the body is constantly producing a steady stream of experiences. And how we interpret those experiences has a huge bearing on whether we're likely to get caught in a chronic pain cycle or not. Take a moment now to close your eyes. And breathe a little bit. And I want you to bring your attention to the sensations in your left foot. Leave your eyes closed and just tune into what's happening in your left foot. And notice what's going on there, maybe a kind of tingling or a pulsing or a pressure, and notice how it's actually different from what's happening in your right foot. Just could be the beginning of peripheral neuropathy. There's an awful lot going on there, and it doesn't feel right, does it? You can open your eyes again. It doesn't take much. All we need is to bring fearful attention to a body part and add to that a frightening diagnosis, and we are off to the races with these kinds of things. So we have 2 options when something arises like this in the body. We can think it's probably nothing. These are survivors of near-flu experiences. I felt achy and awful, then suddenly it went away. I thought I was getting a chill, but as it turns out, I was just cold. I asked myself, am I a tiny bit nauseous? 5 minutes later, I felt just fine. If you don't have a trauma history, and you don't come from a certain ethnicity that calls specialists a lot, and you're younger, so you haven't heard of a lot of horrible things happening to people, and you get weird sensations in your body, you think it's probably nothing. If, on the other hand, you come from one of those other ethnicities, or you've been exposed to trauma, or you're a bit older, you start thinking, uh-oh. She's reading the big book of horrible rare diseases. By her feet is the Merck manual, my favorite go-to instrument before the internet. Everything you always wanted to know about scurvy, but were afraid to ask. A Child's Garden of Maladies, Lockjaw Monthly, etc. And of course, we can err in either direction, right? If you know, the kind of people, and sometimes I think this happens from people who have been through trauma who have done the reptilian vagal nerve maneuver where everything has shut down. People who are very shut down, they get to the point of, yeah, well, there was a grapefruit-sized kind of thing on my neck, but I figured it was probably a zit, right? Now, that kind of under-arousal, under-responsiveness is quite problematic, but many, many people go in the other direction. They become terribly focused on these things and terribly frightened about what they may mean. Then they pursue medical evaluations. You know that if you pursue medical evaluations for any disorder, sooner or later somebody will find an anomaly and will attribute the problem to that anomaly. And we don't have time to get into this, but for example, in the case of chronic back pain, it turns out that the vast majority of variations in the spine that are pointed to by orthopedists often, the data says they're coincidental to the pain. These things are normally distributed in the pain-free population. Once you get the frightening diagnosis, you're off to the races. Now, for many of us, when we experience some kind of pain in the body, we are able to soothe, right? We're able to feel held in some way. It's okay, sweetheart, it's going to be all right. We have childhood memories of this happening around disease, and we tend not to get overly aroused and freaked out by it. But we know that for folks with trauma histories, this kind of soothing does not happen so easily at all. In fact, when there's pain in the body, they're much more likely to spiral into a kind of dysregulated, fearful circumstance. And we've demonstrated what fear does in the body. That's going to amplify the muscle tension. It's going to amplify the distress. And it's actually going to do it in two ways. First, the muscle tension hurts. The other thing is we've got all sorts of data that says if we pay attention to a sensation in the body, excuse me, with fear, we actually feel it more strongly. They do cold pressor tests in which they insert somebody's hand in ice water, and if they tell the subject that you'll only have to hold it in there for 30 seconds, and they ask them after 15 seconds to rate their pain, they'll say, well, it's like a 2 on a scale of 1 to 10. If they tell them you're going to have to keep it in for 10 minutes, rate your pain after 15 seconds, they'll say, oh, it's an 8, and I'm not going to do this for 10 minutes. I can't bear this. So the same peripheral nervous sensation is experienced very, very differently depending on whether or not we have fear. Finally, the last component is our capacity to split off experience. Many of you will remember him. He was one of the earlier models for alexithymia, for what we had before Asperger's, which was the propensity to not identify feeling states. And we know that while many people who've suffered from trauma are flooded by feeling states, most people have an awful lot that they're still blocking out of awareness, the mechanisms that John was talking about. And this mechanism of blocking it out of awareness is a kind of disintegration or a kind of mild or more severe dissociation. And what happens is, as one of my patients put it, when you bury feelings, you bury them alive. You know, we do not get rid of them. You were talking about Wegner's research, that they're constantly there, they're constantly active in our unconscious mind. And as a result, every time a bit of one of these memories, an unwanted affect, a disavowed thought starts to gurgle around unconsciously, we tense. And every time we tense, we're back more predisposed to this kind of cycle. So it's basically all of these factors that predispose folks with chronic pain to these kinds of disorders. There's other models too, like Peter Levine's model about kind of the frozen discharge response, which I think is a good model as well. So how are we going to use mindfulness to help with this in 4 minutes? Well, we're probably not going to do it in 4 minutes, but you know, the central story becomes the Buddha's sutra of the 2 arrows. When touched with a feeling of pain, the uninstructed run-of-the-mill person sorrows, grieves, and laments. We will make this less sexist. Beats his or her breast, becomes distraught. So the person feels 2 pains, physical and mental, just as if they were to shoot a person with an arrow and right afterward were to shoot him or her with another one. So the person would feel the pains of 2 arrows. So this is the notion that when we're dealing with pain, physical or emotional, there's really 2 aspects to it. There's the moment-to-moment sensations. And we know from neurobiological research that meditators are actually really good at being with the first arrow, at feeling the moment-to-moment sensations of the pain. And meditators, when they do this, they do experimentally induced pain where they put somebody in a functional MRI machine and shock their feet. The meditators have a lot of insula activity. They're feeling it strongly, but not a lot of prefrontal activity. They're not evaluating it in a big way. They're not getting into all the stories of, oh, this is horrible, oh, damn, when will this ever stop, etc. Non-meditators don't feel it as strongly. They don't have as much insula activation, but they have a lot of evaluative thoughts about it, a lot of hating it, resisting it, and this kind of thing. And it's the hating and the resisting of it which feeds into the emotions, which feeds into the difficulties about it. So we come up with this well-known formula that pain times resistance equals suffering, and that it is that what we wind up working with mindfulness practice is lowering the resistance so that people can simply be with painful experience. And I'm going to skip a little bit. And that helps us to develop symptom tolerance, which is really important for working your way out of this. Because as long as you're afraid of the pain, and as long as you feel that if I'm in pain, I mustn't do anything that hurts, well, then you're never going to be able to rehabilitate yourself from whatever the thing is, whether it's that I'm afraid to eat a tomato because of GI distress, or I'm afraid of loud noise because I have hyperacusis, or I'm afraid to bend and lift because I have chronic back pain, on and on and on, whatever the syndrome might be. If you're afraid of the symptom and of experiencing the symptom, you're not going to be able to re-engage in your life. So you can use mindfulness practice to help people to do this, and it's a little bit of a longer story as to how to do that than we have time to discuss. Mindfulness practice also helps in another huge part of this, which is to simply believe that the mind might be playing a significant enough role to be creating the symptoms. Because if you can't imagine that, then it's very hard to go ahead with the psychologically oriented treatment. And I do a lot of teaching patients about placebo studies and just the remarkable power of the mind to affect the body. And I also suggest that they use mindfulness practice to notice the prevalence of anxious thought and feeling about their symptom. How many times in the course of an hour do you check in and think, how's my back doing? How's my head doing? What's my stomach up to? Am I going to have to go to the bathroom? And people who start taking up mindfulness practice start to notice, oh my God, if I'm struggling with one of these symptoms, I'm doing this all day long. And they get it that, gosh, I'm actually something of an anxious wreck. I just get a little tense before everything, is what we discover when we take up mindfulness practice. And seeing the pervasiveness of that becomes very, very useful. And we can also use mindfulness practice, and I imagine others will talk about that, as a kind of psychodynamic exploratory technique, as a way to get in touch with and be with some of the emotions that have been disavowed. But of course, that requires timing and safety, because we're not going to just rush into that with trauma survivors. So at 18 minutes to summarize, we're not talking about using this as relaxation training. Yeah, you could do that, but it's kind of boring and I don't think it works very well. And in fact, the studies about mindfulness practice to treat chronic pain, the results are not so great. Because my thought is what's happening is they're mostly trying to use it as relaxation training. They're not using it to increase symptom tolerance as part of a rehabilitation program that's going to get people back into their lives so they're not going to be afraid of this. They're not using it as a tool for the psychodynamic exploration to be able to bit by bit gradually reintegrate the trauma. They're not using the self-compassion aspects of the tradition to work on helping people to self-soothe and not freak out so much. So it's actually a basket of techniques that we can use in a lot of different ways to foster cognitive change, to no longer see this as just a medical problem, to increase symptom tolerance, to offer self-soothing, and to uncover and integrate split-off contents. If you're interested in mindfulness practice for chronic pain, there's a website, backsense.org, and a book that we put together which is used for treating chronic back pain, but it can be used for other things. And then, well, we'll pass out resources in some other way. But some meditations, including meditations on chronic back pain, are at mindfulnesssolution.com, which is a website of some of my stuff. 78 RPM, for those of you who remember what that means. Thank you very much.
So good morning. Feels like afternoon. So I'm really delighted to be here and to share with you some data we have. And I'm realizing after hearing these wonderful talks, last night and today, that my talk is actually a little bit more particulars, and sort of I'm going to want to share with you some data from and some background a little bit from a particular study that we've done at the Ann Arbor Veterans Administration Hospital, in which we're looking at a particular form of utilizing mindfulness-based approaches and self-compassion-based approaches in a group therapy where we also utilize some of the sort of more standard types of exposure-based therapy. And we have some clinical outcomes and a little bit of neuroimaging, which I'll share with you a bit. So I'll try what I can in 18 minutes anyway. So this project is the result of efforts from a lot of people. The folks on the right, Todd Faber, Sheila Rausch, and Nick Giardino, are all VA PTSD clinic psychologists. Israel Lieberzahn used to be the chief of mental health services at the Ann Arbor VA, and a number of other people. Although I've had the great luck to have some fantastic advisors and consultants. Zindel Siegel is our formal advisor on the grant, but also John Kabat-Zinn and Sharon Salzberg have been very interested and provided some fantastic discussions. And I owe a lot to Kyabje Gelek Rinpoche. It was my personal teacher who has also had a big interest in how can contemplative methods be helpful. So I do have to point, so work is also supported by a number of financial supports. Interestingly enough, I was able to sell compassion to the Army somehow, so we have support from the Department of Defense. So I guess I have to disclose that I am a defense contractor, in a sense. But one trying to promote self-compassion meditation. So we all know that PTSD is a major clinical problem. Interestingly, that has about twice as high a prevalence in women than men. But if you look at the prevalence in combat veterans, maybe not surprisingly, it's very common. And these are from epidemiological studies looking at sort of either loose or tight definitions of PTSD. But symptoms of PTSD come up in a lot of people. And they are very painful, and they can lead to a lot of disability. So on the one hand, I am going to sort of talk a little bit in the mode of sort of the traditional sort of mode of randomized controlled trials and sort of fixing people, and as well as sharing some experiences about some of the things that came up in the groups. And I do think, in a sense, there are sort of two types of people, lumpers or splitters. I tend to think of it there's two types of people. One type of people who divides people into two types of people, and one type who doesn't. But in terms of, I myself have been really loved hearing the presentations, and this morning was, with John's talk about this tension that goes on between the desire to fix, and actually we're not just desire to fix, we're contracted, in a sense, to fix. That's our job. On the one hand. On the other hand, the actual common humanity and the relationships that develop in the therapeutic process with as much authenticity as you can bring, I think is also a big part of the therapeutic process. That doesn't always, it's difficult to measure that in, at least with self-report measures or whatever, but it's our experience. So thinking also about how, you might ask, well, why would you think that something like mindfulness or self-compassion could be helpful? I don't have to talk to this crowd about that, but I want to think about, so I also appreciated what John had to say about mindfulness is, in a sense, a type of exposure. It's an exposure to your mind. You're sort of extemporaneously accessed mental thought, or mental states, including thoughts and emotions that can be quite difficult. And so exposure, we know, is effective in some cases and in many ways for treating trauma, different forms. So mindfulness, in a sense, may be a form of that. As well as there's been a lot of literature, a lot of studies on the metacognition or meta-awareness called decentering and other sorts of things, where it looks like there's a core capacity which is specifically developed in mindfulness practice. And then when I say exposure here, we're not talking about imaginal exposure to a script, as in prolonged exposure, but kind of being able to sit with excess thoughts and feelings. So there's a number, I'll sort of go a little bit quickly due to time, but there's a number of other features, just sort of a priori, theoretically based thinking of why things like mindfulness and self-compassion may be useful as potential tools. Certainly training in the openness and non-judgmental present-centered awareness, this can lead to, or we hope will lead to, some cognitive flexibility, which may be able to work with some of the, oh, thank you. Oh, thank you, dear. Yeah. May be able to help with some of that sort of concreteness and the narrowness, the narrowing which trauma can bring. Also, possibly some of the present-centered awareness of body, thoughts, et cetera, can form as a sort of anchor or grounding, which may be able to help bring people back into their body, become embodied, and help with some of the dissociation. Certainly just the relaxation part, interestingly, although a lot of work, I think very appropriately, sort of talks about how mindfulness is not just relaxation, but it also comes with, very often, some sense of a parasympathetic response and sort of being able to be comfortable in your body as you can be. And certainly the self-compassion and loving kindness may be helpful for guilt and numbing. So that's what I'll say about mechanisms or potential mechanisms. But there are also some challenges of treatment of PTSD in general in veteran populations or really in any population, but non-specific things around, OEF, OEF stands for Operation Enduring Freedom, Operation Iraqi Freedom. Apparently the original, it was originally Operation Iraqi Liberation, but the acronym didn't work very well. So it was OIL. So there are some challenges in the treatment of PTSD in veterans population. There's a big dropout, understandably. So even scheduling is problematic. There's stigma. But then when you talk about something like mindfulness, self-compassion, maybe, I was concerned. Is this going to be culturally acceptable to people who have been trained and who have, and in very cases, I think, very honorable, very idealistic, very hardworking, very caring individuals? Is this kind of too weird? Are they just too busy? We also know that PTSD has concentration problems, part of it, as part of its the symptoms. So will people with PTSD kind of have the cognitive resources to actually even engage in this, or are we sort of setting them up for something they can't do? And also the idea or the phenomena of anxiety-induced, relaxation-induced anxiety. So what's going to happen when we ask people to sit for 5 minutes when they have, for the last 5 years, been really trying hard never, ever to sit quietly for 5 minutes because they'll get jumped. So, and a fair question. So there are effective empirically supported. This is more for the RCT crowd. So I'll show you some data. This is data from a large VA study. The y-axis is the CAPS, the clinician-administered PTSD scale. About 50 is considered sort of a rough cutoff for PTSD. And you see that over time, from pre to post and then in follow-up, that it's reasonably effective. However, group therapies, interestingly enough, at least from the published literature, group therapies are very popular and very useful in the sense of patients say they like them, clinicians say they like them, the VA likes them because they cost less, but don't see as much of a symptom change, at least in the published literature. So this was part of the rationale how we were able to kind of sell the study, is can we do something in groups that will increase engagement and lead to possibly more symptom reduction. So I'm going to go through a little bit quickly. Pilot study used the green, who's seen the Green Book? Zindel Siegel, Mark Williams, and Teasdale. This is the Mindfulness-Based Cognitive Therapy for Depression, Relapse. We pretty much used that and kind of just tweaked it a little bit. We just adapted it for PTSD. We did some things, including decreasing the length of, not the sessions. The sessions were almost 2 hours, but the individual meditation or the mindfulness practice, we did 10 to 15, 20 minutes max, never 45 minutes. And also had attention to distress, flashbacks, et cetera. And we added some loving kindness. And this is so this is published. Some other stuff I'll show you is not. But we did a little pilot study. We compared it to sort of a TAU's test for treatment as usual. This was another 8-week psychoeducation course, which is sort of the intro. And what we found is a statistically significant decrease in PTSD symptoms. Interestingly, it was mainly accounted for by avoidance symptoms. And the reports we got back, this was with mainly Vietnam veterans and some people on Desert Storm, was that they were engaging more with their life. It was kind of okay to start noticing things. One veteran said that he noticed his wife was a good cook after being married for 30 years. We did some mindful eating, which I thought was great. And as well, in addition to symptoms going down, we saw some change in, this is called the Post-Traumatic Cognitions Inventory by Edna Foa. We also saw some change in cognitions about the world being dangerous, about the self being inadequate, and about it's all my fault. Did change. So this was a pilot study, open label, but we used this to be able to ask, to get the support to build a specific group intervention, which would be somewhat longer. We proposed a 16-week intervention, which incorporates mindfulness and self-compassion training, as well as aspects of exposure therapy, specifically here in vivo exposure. We're not processing traumatic memories in group, but we are encouraging veterans to interact with their life, to sort of take parts of their life back. We call that mindfulness-based exposure therapy, and we compare it to an active group control therapy, which I don't have time to describe, but it was developed at the VA. It was in the graph that I showed previously with about an 8-point reduction in CAPS. And our experimental design was fairly standard, randomized controlled trial, 2 arms. We did functional magnetic resonance imaging before and after. And the groups sort of had some commonality. So the psychoeducation in the beginning, the first 4 weeks, was pretty similar between the 2 groups. And then within the mindfulness-based group, the mindfulness-based cognitive therapy components were sort of starting in like week 3 and going. We also introduced some, as I'll talk about, some in vivo exposure. So we used the standard material from MBCT, the raisin exercise, mindful eating, in vivo mindfulness, the body scan, which is a really wonderful thing, as well as some, I call it mindful stretching, because I'm not a yoga teacher or a Qigong master or whatever, but we did some things that are pretty basic: standing, holding up your arms, sitting down, and mindfulness of breath, sound, and emotions. But we also added some specific, PTSD-specific, quote-unquote, material. We actually, at first, we didn't say mindfulness at all. We said relaxation. We embraced the R word, and said that, yeah, because there's some, they can get it. They can really understand it. Yes, I am going to, and we talked about stress physiology, PTSD, psychoeducation, common effects of trauma. And then we started to introduce the idea of mindfulness and how this may be useful for coping. We also did with something, this is based on the MBCT Pleasant Events Calendar, which we call mindful behavioral activation. Actually, it's finding areas in your life that you enjoyed. And first, very commonly say, well, I don't enjoy anything. Well, let's challenge you. There might be something you enjoy. Let's start to really bring the mindfulness skills that you're doing by sitting for 15 minutes into noticing that and bringing that into your life. Mindful in vivo exposure is basically also trying to use some of the mindfulness skills developed from formal practice in a standard in vivo exposure paradigms. And also the idea that that mindfulness is to be used not as a way to avoid, but actually as a way to ground into the present and start to look actually for safety cues in the environment, recognizing that this is actually a grocery store. This is a lot of guys went to Meijer or Myers, depending upon your vocal habits, but it is a grocery store. What are the aspects of this grocery store? And right now, this is not a patrol in Iraq. So given that I have about 5 minutes, so also we did some ways, so in terms of self-compassion, we started with noticing ways that veterans with PTSD can be much harder on themselves than they are on other people. And I invited them, it's somewhat comical almost, inviting them to talk about, imagine a situation in which you've kind of done something wrong, you've done a faux pas, feel awkward. Please describe how you feel about yourself. What type of language do you use about yourself? I can't repeat it here, I'm sorry, what they had to say, but it was pretty harsh, and sort of bringing that to mind. We did some work with actual loving kindness. This was actually very accepted. I was, to my delight and somewhat surprised, they actually really liked doing this, especially when we used so starting with the beloved, moving actually to a neutral but another veteran. So not exactly neutral, but somebody they don't know well, but thinking of another veteran who may be suffering from symptoms of PTSD. How would you treat them? How would you think about them? And you're also a vet. Isn't it appropriate that you might be kind to yourself? This is some of the data. I promise I'll show you some facts and figures. The mindfulness, MBET is mindfulness-based exposure therapy. This is just looking at how many people stayed in the group. And we saw a dropout rate of about 10% in the mindfulness group. We saw a dropout rate, unfortunately, about 75%. In the VA-developed present-centered group therapy. The VA actually asked us to stop doing that group because it was considered ineffective. So that sort of shot a little bit of the technical, statistical analysis, but what can you do? This is actually showing the clinical outcomes. There was a statistically significant effect size pre-post, but the between-group effect, this is an intent-to-treat analysis, was trend level at this point, but it looks potentially encouraging. You'll notice, though, this is group therapy. We saw about a 17-point reduction in CAPS, not a 40-point reduction. Individual therapy, you get 40 to 50-point drops. So I think it's important to note that, but also to note that this did not do any trauma processing at all. This was, we didn't, anyway, I don't have time to discuss the specifics, but we were really focused on your life now. Rumination did go down. We're very interested in the potential mechanism. So summary, I'll show you something. I think I have about 2 minutes left, so I'll show you 2 minutes of a bit of neurobiology. We know that PTSD, a lot of studies of neuroimaging, and that different areas, the amygdala, this is this little red bit here, appears to be hyper responsive, whereas different parts of the medial frontal cortex and dorsal anterior cingulate appear to be under-responsive. So this is one of the tasks we gave, so to look at these faces. Which face on the bottom is expressing the same emotion as the face on the top? Anybody care to guess? Right or left? Yeah. Okay, so that's a task. We didn't really care about their ability to, just looking at those faces activates your amygdala. So I beg your pardon, I've just activated all of your amygdalas. And faces are very good probes for that. What we found, we looked for areas in the brain which then changed in relationship, that got actually brain activity that increased as PTSD symptoms decreased or improved. And we actually found this area here in the dorsal, the rostral anterior cingulate medial frontal cortex that appeared to correlate. Increasing activity in this brain area appeared to correlate with improvement in PTSD across both groups. When we actually look specifically, we're also looking, are there any mindfulness and self-compassion group specific changes in brain activity? We did some of the statisticians, we did something called a flexible Anova. We looked for a group by time interaction in SPM, which is a neuroimaging statistical software. And what we found actually in the people who did the mindfulness group, we saw increased activity in this dorsal medial prefrontal cortex region. In the interaction, which is a rather conservative test, we also looked at pre-post in the mindfulness group only, and we saw sort of a similar area, and we looked between the groups post-therapy. And again, the mindfulness group had greater activity in this dorsal medial prefrontal cortex. This is an area associated with many things, but including emotional regulation. In 1 minute, I'll try, I can't describe the default mode network, but basically there's large-scale interactive connectivity networks within the brain, and one of them, and the many of them, one of them is kind of associated with, sometimes they call it task negative or resting, internal dialogue, mind wandering, you know, sort of what you do when you're not doing anything. And this is associated with tight coupling between the posterior cingulate cortex and the ventral medial prefrontal cortex. This is altered in things like ADHD and depression. Also some evidence from Judson Brewer and David Cresswell and others that this may be altered in meditation. So people who are expert meditators or who are even novice meditators may see some changes in this region. And it's also decreased in post-traumatic stress disorder, and it appears that cross-network connectivity, this is some work from our lab, appears to be increased. So whereas people don't have as tight of coupling of the normal resting state, they tend to, and we think that this is related to hyperarousal, that they're actually salience network and other things are kind of creeping in to your normal because you're attending to potential danger. So in 1 minute, let's say we did both in healthy people, we did sort of a standard, a little bit of a version of MBSR that was similar to what we're doing in the mindfulness-based exposure therapy for PTSD. And in the PTSD group alone, if we looked at these two groups of people, we actually saw from pre to post an increase, and this is interesting because it's cross-network connectivity, which I just told you is sort of increased in a sense in PTSD, but it's cross-network connectivity with areas on the dorsolateral prefrontal cortex. And it's interesting, here are the PTSD patients, here are the healthy patients, and similar patterns. And actually, when you put the groups together, the main effect was quite strong. Very similar to Judson's work. So suggesting that the patterns in PTSD and people with PTSD doing mindfulness actually look similar to patterns of healthy people. This is actually comparing the two PTSD groups, the one on the left who did the mindfulness training, the one on the right who did not do the mindfulness training, and we actually see a really big difference in how the default mode network changed. So I'm sure that I'm out of time by now, but in summary, I'll just say that, you know, it looks like there's some indications that this may be a useful approach, that it's culturally acceptable to veterans with PTSD. It can be delivered. We didn't get kicked out of the VA. Actually, we got the other group got kicked out of the VA, so interestingly enough. It does appear to be to also associate it with some potential. I mean, this is a small pilot study with about a total, although we recruited about 60 veterans, really it's about only about 25 got imaged. But there's some indications that there may be some changing in regions of the brain that kind of make sense in terms of emotional regulation in PTSD. So thank you very much.
I'm going to make a few comments about Jim Hopper and my chapter in the book, Intensive Vipassana Meditation Practice for Traumatized Prisoners. And we write about the introduction of a 10-day Vipassana program into a maximum security prison in Alabama. That's 100 hours of meditation over the course of 10 days. And we describe with this program how trauma is accessed, processed, and integrated in a safe and clinically effective manner. Now, many of you are probably familiar with this story of this prison and this program through the documentary film, The Dhamma Brothers, and there's also a book of their letters from the Dhamma Brothers. But I've always felt that this story has such, I mean, not to knock the book and the film, but the story has such great implications for criminal justice policy and reform. And so I was just thrilled to have a chapter in a truly clinical book. I just wanted to say a little bit about my own introduction into prisons and how I got there, and a little bit about where I am today. I had been managing a mental health program in a medical center in Concord, Massachusetts, and I had my own psychotherapy practice there. And it was about 16 years ago that I decided that I really wanted to take my work to the streets. I mean, I was going to continue doing traditional outpatient practice, but I wanted to work with a population that was high risk and underserved. And it was about that time I heard about a program called Alternatives to Violence. And actually, one of the national coordinators, Nancy Shippen, for that program happens to be here today. But I went into prison. It was just the prison down the street from my house that I'd never given really two thoughts to. And so I decided to go in and as a participant, which was really interesting because I wasn't going in to instruct anybody about anything. I was going in to participate in this program, and a lot of the work was done in very small groups. And just as an example, there was we had an activity called Build Your Dream House or something like that. You probably all heard of this, but we sat in very small groups, maybe 4 or 5 people, on the floor with a big piece of poster paper, and you weren't allowed to communicate with one another in any way, verbally or through body language. You just made another line on the dream house you were creating together. And there was so much of a sense of collaboration as we did this together, even though we weren't signaling one another in any way. And I went through 3 weekends of training in AVP, and it really blew all my stereotypes away. And John talked about something, they are us, like Toys R Us. Well, I would say prisoners are us, and I discovered that then. And it was right after that that I made a decision that I wanted to teach a slightly different program because it was more of a clinical therapy program. And I've been teaching for the last 6 years a program called Houses of Healing, which is a manualized treatment program. Many of you maybe have heard of it. And it's very grounded in principles of mindfulness and meditation. And so I've been teaching that for 16 years. I very much made the program my own, as you're supposed to, or it's expected you integrate a lot of your own things that you want to bring into the program. But I've taught it on every level, from the county jail to the Supermax. In fact, at one point at Suffolk County House of Correction, we actually had a Houses of Healing treatment pod there, and it was intensive immersion inside the prison. It was quite a long time ago. And I've always, since then, every time I run a group, I've noticed that these are human beings. Shouldn't be such a shock. If I say prisoners are us, prisoners are me. But these are human beings who are desperately in need of treatment, of help, of assistance, and they need it. They work so hard, and that's been a big surprise for me. And maybe many of you maybe have worked with prisoners, but it's such a secret to know that when nobody seems to realize, and that's why I made the film, that when you go in these places, these people really, really, they don't want to fool around. They want to work, and they want to figure out a way to live their lives better. Prisoners are a vastly different landscape than we ordinarily live within. I think of prison as the great battlefield for the human soul. But I've also learned over these years that this can be a time for healing and for deep personal change, personal transformation. under the right conditions. And that's what our chapter is about, is what are the conditions under which you can do this type of treatment safely and effectively inside of a maximum security prison. And we also explain how the treatment program works. I just want to give 2 examples of well-known prisoners who really use their incarceration in interesting and ways to better themselves. And I guess one of the most famous prisoners of all time is Nelson Mandela. And he entered prison one day, and he walked out 27 years later. And he never, well, he might have lost his focus at some points along the way, but he really kept focus. He had a rigid routine that he created for himself. He got up at the crack of dawn every morning in the dark, made his bed, folded his pajamas, put them on his pillow, tidied up his cell, and started walking. And he walked for miles and miles in that tiny cell. He was actually in 3 different prisons. There were different sorts of places where he was enclosed, but he never lost that focus. He was a boxer anyway, professionally. So he kept that sort of boxer. In fact, when he walked out 27 years later, he walked like a boxer. He used his time to sharpen his political skills and prepare himself for future greatness. I think one of the things that really interests me about Nelson Mandela is that he used his incarceration time to work with his mind. He wasn't just developing political strategies, which of course he was doing with the brotherhood of men that were in there with him. And if you read about what he was doing while he was there, it's amazing the strategies he was crafting. But he also knew about working with the mind. And I'll read you a quote from him. "You may find that the cell is an ideal place to get to know yourself, to search realistically and regularly the process of your own mind and feelings. At least, if nothing else, the cell gives you the opportunity to look daily into your entire conduct, to overcome the bad and develop whatever is good in you. Regular meditation, say of about 15 minutes a day before you turn in, can be very fruitful in this regard. You may find it difficult at first to pinpoint the negative factors in your life, but the 10th attempt may reap rich rewards." So another prisoner that I'll mention is actually from literature. It's Dostoyevsky's Raskolnikov in Crime and Punishment. And Raskolnikov was a pathetic, disturbed, delusional man. He killed 2 women for no particular reason. One because he sort of planned to do it for no particular, and the other because she was there when he was killing the woman. Interestingly enough, at the end of this very long book, he's in prison, and he's got such a tortured mind throughout the book. And he's beginning, during his imprisonment, to develop a sense of self-awareness. And that self-awareness is actually growing into love and compassion. And I thought to myself, how did Dostoyevsky know about the possibility for such a thing? Well, he was himself a prisoner. He was a political prisoner in Siberia. And at one point, he was taken in front of a mock firing squad, and he was about to be executed. And then they didn't, because it was just a mock squad. But it must have been, I don't even know how to talk about an experience like that. But so I think that both Mandela's political genius and Dostoyevsky's writings were informed by their deep suffering as prisoners. Okay, so how do we harness this yearning for inner freedom and meaning that prisoners have so often? I won't say without exception, but I find very few that if you scratch the surface, you won't find something that can be harnessed, that they're wishing for and needing, and that could be offered through a good treatment program. My quest, besides my own work that I do running groups in prison, which is very small scale, but is to create a national awareness about the need for and the effectiveness of prison treatment programs. We know through research that just getting a GED or taking a course in barbershop techniques or car mechanics, these are typical prison fare, that will reduce recidivism. So I think it's wasteful and unjust not to offer psychological and contemplative treatment programs. And actually, I think it's unjust not to offer trauma treatment with this huge 2.4 million pool of mostly traumatized people. So if you could imagine a prison that's accepting of and supportive of a deep, intense treatment program that has the space and the time to run this program smoothly, well, that's what happened in this Alabama prison. And it's going on today. 8 years later, this program is still going in the prison. I know it could disappear at any moment, and that's just the way prisons are. But so far, it's still being maintained. 4 10-day programs a year, and then interspersed with that are 3-day programs for the old students they're referred to in the Vipassana community, meaning they've already had a 10-day course. I don't want to romanticize this place. It's really a terrible dungeon. And that's kind of the yin and the yang. There's the spirituality and there's the dungeon-like conditions, and I always find those. But this is a particularly difficult place to survive in. It's considered the end of the line in the Alabama correctional system. But this program has become a part of the institutional framework of the prison. So I want to just mention a little bit about what are the essential requirements to run such a program in such a place. First of all, safety. And safety is a big, big, big word because you're not safe. It's a staggering, traumatizing, re-traumatizing, dangerous, depressing environment. So safety means that you are taken across a threshold into a locked area. You're locked in, not to lock you in, but to lock out the prison environment. So when you're in this refuge, you know that nothing from the outside is going to come in. There's a peaceful officer, one officer at a time, that comes in and sits there for security reasons, but actually these officers have turned out to be very nurturing. Once prisoners cross that threshold, they're no longer referred to as prisoners. They're students, and the teachers only call them students. They're not prisoners in there. There's quiet, no talking, except if you need to talk to the teacher, no chit-chatting. Very unusual in a prison to have people not constantly talking. There's a structure, there's a daily schedule. Everybody knows what this schedule is, what the rules are. It's very ongoing and predictable. But most of all, there are the teachers, and they offer loving kindness and compassion from the moment that they all enter the refuge together. The skills, anapanasati for the first 3 days, meaning observing your breath as it goes in and out of your nostrils. And then on day 4, they begin the practice, they're taught the practice of Aposana, which is systematically moving your mind throughout your awareness, throughout your body. And this is an internal focus. And when these guys go from an external focus, they're used to an external focus. When they go into an internal focus, I mean, it's very enlightening to them. It's a place they've never been. They get frightened, they get triggered, but the teachers and the refuge is there. The whole refuge is a container for promoting the practice. The students must journey inside and observe with focus and equanimity the afflictive habits of their mind through a deep interoceptive engagement. They observe and accept their most turbulent, traumatic memories, actions, experiences, and emotions that have been unavailable previously as they were ripping and running through their lives, just living on the surface of their minds. This is a tall order for prisoners, and I completely understand that. They're shut down, they're locked up, they can only focus on the external. Nothing else is possible unless they have the training and the support. But I've always found they're right there, waiting and wanting to go through this process. And at the end of their journey, they speak in such an informed way about their experiences with their suffering, with really being with their suffering, with non-attachment. They speak about non-self, and impermanence. And I just want to, in closing, read you a letter that I got fairly recently from a guy named Johnny Mack. And he is in his 60s. He's been locked up most of his life since he was a very young teen. He's been trying to get out of prison every time he's in there. He can't sit with his incarceration. He can't sit with where he is. He's always moving and frequently trying to escape. He's been violent. And so when Vipassana arrived at this prison, Johnny, like many others, jumped at it. Maybe this will be my way to freedom. So I want to read you his letter. And I think one of the compelling things about his letter for me is how he describes his feelings of being part of the universe. Not an easy thing when you're locked in concrete and, locked far away from the universe, but he feels part of it. And these are his words. I haven't doctored this at all. Dear Jenny, I once said of Vipassana meditation, this feels like freedom. I spoke only of what I was feeling at that time. I had no reason, not even the idea, that has attached itself to me these last 6 weeks. And during that time, I've been meditating in my cell for 4 hours a day. It's also very clear to me now. Vipassana is freedom. It's the freedom I believe with all my being that very few people attain. I have none of those longings to be out of here. At the same time, I don't have the desire to be here. Everything is just so right. All things are connected, and I'm just a tiny part of the universal beauty. I'm not always able to maintain this level of pure contentment. I sometimes become sad until I realize I've developed attachments, and I quickly find balance. It's so wonderful to be detached while at the same time to be a part of a stream that flows through everything. Jenny, I don't know that words could really communicate these feelings, but I simply tried to tell you about them. I think I'm missing something, but even that is okay. Much metta. Johnny Mack.
Wow.
So, Dr. Briere will, or John as we call him.
John, we call him.
Or Teddy Bear, some of the stuff, is going to open the discussion, and then there'll be time for questions.
Yeah, I could have done comments, but you heard enough of me earlier. Plus, this was such a brilliant collection of things together. They didn't fit together perfectly, but that's actually how the world is without artifice, right? That's actually how things are. I just loved it all. I loved every single one of them. Some of these people I know well, some I don't know too well, and I just adored the whole thing. I think that what we should probably do is just leap right to your reactions and their responses to your reactions, and then usually after that comes enlightenment or something like that. So don't walk away before then, actually.
I have one comment.
Except for one comment.
If you haven't seen the film, you must see
Yes.
it. It is so moving, and it changed the way I saw the world in terms of how we treat people in prison.
It's
Jen-
called the Dhamma Brothers. Dhamma is the Pali word. Sanskrit is Dharma. These guys called themselves the Dhamma Brothers. They were actually taught a lot of the terminology from the Pali Canon, a lot of the words, and they became very familiar with them, and they decided to call themselves the Dhamma Brothers. And I had some simple idea of what I was going to call the film, and then, wow, when they began calling themselves that, I realized that was a good title. Yeah, so it's DHAMMA. And my website is dhammabrothers.com if you want to get any, you can see video clips and read letters that they wrote and things like that.
Okay, so let's do it. There's a microphone coming to you.
30 years a teacher, I project pretty well. I am Nancy Shippen. I am very active with AVP locally, nationally, internationally, and the Friends Peace Teams. I totally invite you all to come into prison. There Framingham Prison, women's prison, is actually now a trauma-informed care place. We can't convince people that the men are traumatized. You know, they're just them. They're those people. So we need your awareness and your practice in every way. So that's what I want to say, and just second the fact that if you ever felt you needed any kind of experience to take care of racism, sexism, ableism, humanism, or something, then I can't say anything could be a better spot than an AVP workshop where you, over 3 days, just become profoundly interconnected.
I have a question for Tony. You talk about mindfulness helping strengthen the prefrontal cortex. So I'm wondering what your experience is with vets particularly who have suffered traumatic brain injury and they pretty much knocked out that anatomical center.
Thanks very much. So in this particular group, TBI, both MTBI and more strong forms of TBI was an exclusion. So we didn't actually work with people. That's just for, because we're doing neuroimaging. It's very interesting. Of course, more severe forms of TBI, ironically, in some ways, can be protective of some sorts of, if you have retrograde amnesia, for example, people tend to have less symptoms of PTSD, just like when there's more recent, well, about a year and a half ago, a big study came out that availability of morphine or other opioids on the battlefield, very close to the trauma, is also protective. So, the short answer is I don't know. I mean, I think that there has been work with people with mild cognitive impairment doing attention training and mindfulness training, which was also seen to be helpful. So I don't know, but I think, I don't think it's doing any harm. And so
I think most people think that if you look at MTBI, you can do everything you always did, just do it more carefully, a little slower, keep track of the operating conditions. But it's one of those things where people can get weeded out of things that can really be helpful for them. Also, frontal injury or a defect or a lesion in some area of the brain is not very easily described. Everybody has a different heterogeneous process there, and you can't really say, sorry, your frontal lobes are funky, therefore you shouldn't get this thing or that. So what you find actually in hospitals and other environments where you're looking at people who have cognitive deficits, we don't screen out traumatic brain injury. For one thing, if you're working in trauma, that would screen out a fairly large group of people, and it's just not that helpful.
And I will say, actually, another study, not a study I did, but a study that Sheila Rausch did, looked at using forms of exposure therapy in veterans with PTSD and or MTBI. And it looked like people with MTBI, mild traumatic, post-concussive syndrome, there was no difference in the level of improvement. So it looks like it doesn't. Yeah.
Thank you all so much for everything you've offered. And I also appreciate the presenters last night. And the opening presenter mentioned complex trauma and specifically racial trauma. And I was just wondering if anyone has any experience with any of these techniques being applied to individuals who are living with racial trauma.
I didn't hear the last few words.
If anyone has any experience with any of these techniques being applied to people living with racial trauma.
I'm not even on this panel, and I might speak again. We have this large federal grant. We're providing psychological services to multi-traumatized inner city kids. And we just decided to reframe the whole CBT thing. So the whole cognitive component, they actually have time where they specifically deal with the traumas of racism and other things as a perfectly legitimate target of their work. So it actually freaks out visitors because they expect to be seeing the regular Patty Reesick thing. Instead, they're seeing these people talking about what it feels like to be treated the way that they've been treated and the kind of coalitions they form among themselves to develop a broader perspective there. So, what I think is happening, post-slavery syndrome and the different names that are being used for this stuff, I think are really a wonderful development. It's so interesting that we collectively in America have repressed and developed dissociative amnesia for the fact that what we've done in this country is almost, it's right up there with the bad guys of the universe in terms of just a couple of generations ago, people's relatives in this room owned people's relatives in this room. And that kind of a trauma is not in any way easily overlooked. But because we develop a dissociative amnesia between what happened then and what happened now, and then we say, well, look at these people. I mean, my own experience of working with Aboriginal cultures in the world is it's unified. That you treat a group of people really bad, then they have problems, and then you go, see, that's why we treat them bad. So there's a real, I'm very interested in this stuff, and that's why our model, which is called Integrative Treatment of Complex Trauma for Youth, is a model to literally look at the effects of homophobia, racism, sexism, et cetera, as perfectly legitimate traumas. But again, so pervasive that we tend to, out of guilt and fear, we tend to not look at them at all.
Yeah, I'll say,
Oh,
sorry. I was going to say, so not in the research I've done, but by doing, I've led a couple of meditation groups in Jackson Prison in Michigan. And one of the most profound things that happened to me was, just leading a little meditation class. And in terms of racial trauma and probably institutionalization as well, this one elderly gentleman, sorry, it was an interesting experience. So what he'd said to us, this is at the end of the class, he says, I never thought this was for me. I'm a bad person. I'm a crook. I've been incarcerated for 30 years. I didn't think I could ever, meditation was not something that was allowed for me. It's really interesting.
I'm fortunate to work with several amazing graduate students, and so one of my graduate students who's a Latina from a very traditional background and unusual that she went to college, much less graduate school. So she is devoting herself to transforming the work we're doing to fit where I live. There's a very large Hispanic Latino community, and one of the things, of course, about that is that it's not just translating. That it's looking at concepts and how they'll fit. And so a lot of what we're doing is kind of not really focus group, individual interventions where we're testing with folks, asking them, how does this feel? What might be a different way to talk about this using your own cultural context that makes it not feel like yet another imposition of somebody else's worldview, language, tools, but is coming more organically of bringing a way of looking at treatment, but having our clients work with us and including dealing with things that, and we've been doing research just to understand people's experience. And we have to remember that we have people who are undocumented and are afraid to talk to anyone and are afraid that somehow this is a trick because we're going to identify them and get them out of the country, or people who are living in situations where they have family in one country and family here, and there's a trauma around the disconnect that happens because of the inability to freely go back and forth between contexts. So surprisingly, in this particular work, there has not been as much done with the Hispanic community as is needed as well, and different experiences, but forms of racial trauma and stigma that individuals have dealt with.
I'd also just like to, if I may for a second, we have another little problem with Buddhism, which is we're very anxious about anger. We believe it's a different emotional state than the other emotional states. Literally Goleman and the Dalai Lama wrote a whole book on anger as an unacceptable or different emotion and how it has to be treated. It's less skillful, or at least our responses to it are, et cetera. So what comes up, of course, is the minute you start doing mindfulness work with oppressed groups, which is very obvious in some cases and less in others, so there's a huge amount of anger, and then what do you do with that stuff? You know, you could almost hear both in psychotherapy and in meditation, you say, you know, encounter your internal experience, and then when people start yelling, you go, oh, you didn't understand. I didn't mean that experience. I meant like cry, okay, or be scared, but not be angry. But anger is a very huge, you know, it's a huge thing, but it's just like everything else. If you have a trauma survivor who says, you say, well, what are you feeling right now? I would like to rip the head off that person and set them on fire with kerosene, and then I'd like to urinate on their smoldering remains. I just made that up. It shows you my my primary process here. I can access that very easily because of my background. You know, a lot of people go, oh, you know, but my view in that is that's your experience, and that's where you actually have to stay, and that's what you should be talking about. So for people to have so much right to be angry, if we don't treat that as an entirely valid emotional state, what we do is we shut people off in very important ways. I don't think that anger gives you strength and empowerment. It's just another affect. But certainly the extent to which we stifle it. You know, I've treated a few activists in my life, and two different people in different oppressed communities, very different oppressed communities, said to me they were afraid that therapy might work. Because they thought if they had successful therapy, they wouldn't be angry anymore, and then they wouldn't be able to be an activist. You know, who knows anything, but my sense is probably what happens is you're not so angry that you can't do a very good job. So you end up that activism improves and becomes more skillful because it's based on being able to see a little more clearly, because anger tends to cloud your feeling. So I just want to put that in there, that we're so weird about anger. Get a bunch of Buddhists together and you get passive aggression just like that, because nobody can express their emotional states around anything that has to do with those kinds of feelings. And if there's any group where that's really going to come up, it's going to be people that have been shit on. That's a technical term. To be shot upon is a very complex thing.
I had the amazing opportunity to work under a federal grant operationalized through Project Place in the south end of Boston, offering mental health services to women and men who had just been released from incarceration through the South End Community Health Center in the south end of Boston. And I'm a Buddhist and only have ever used mindfulness before I became a clinician to interact with disadvantaged kids and just whoever was around. So I didn't know that I was supposed to dumb down their anger, and I had an office like everybody else, and the walls were pretty thin. So we ended up doing most of our work in the park because they figured I'm there for them. This is, you know, no fee. The first big question was, I can come and see you. I don't have any money. I don't even have my my mass health processed yet. But they did. They came, and they, for the most part, got really, really angry. And it was tremendously enlivening for me to be with somebody who was completely okay with being really angry. And it turned out it was an extension of what they had felt and done while incarcerated, and so our big opportunity was to change it rather than it continue. They were still incarcerated, essentially, until a little while later. The population within that population that was most interesting to me, an interesting thing that just came up, is that while most of the individuals were concerned with the experience of being incarcerated and it being sort of an inevitability from their shitty lives, the African American women skipped over that part and were primarily concerned with returning to a racist community. And I was out of my depth. I did not know how to be fully present with that concern, and so discovered a remarkable community of people in the South End who run a bakery and do a lot of work with incarcerated people. But it's extraordinary to me to be in a room where all of these concerns are being addressed in such an intelligent and full-hearted and humble way. And I just hope that I continue to get the chance to learn how to be better.
I appreciate John's comment about not stifling anger, especially from a clinical perspective. And that's even more true in an environment like a prison. I myself work in a prison. In James Gilligan's book, he talks about sadness being the other side of the coin of anger. And so for those of us who are clinically driven, I would think most of us, whenever we feel and observe that intense anger, it's probably coupled with terrible sadness. So it's important to be mindful of that. But this is, I guess, more of a specific question. I think, Tony, you had a slide where you stated that 6 to 9% of women suffer PTSD, and that 13 to 20% of men. Is that in the general population?
So it's the other way around. It was 6 to 9% of men and 13 to 20% of women. That's just cobbled from, that's in the general population. Yeah, it's coming from the National Women's Study, the Kessler's National Comorbidity Study. It's epidemiology. It's the, you know.
Well, I guess my question is if there are any studies that you're aware of, and I don't know the literature that well, that have data for that for people who are in prison, whether that would be inmates themselves or corrections officers.
There's not enough research out there, but, somebody has?
Wait a minute, we should mic her so people can hear.
It's on recording.
Okay, wow.
Mary Gilfus has done a lot of studies in women's prisons about trauma in the women's population. So that's one name that I know I can refer you to. Gilfus, Gilfus.
Well, what's been your experience?
Well, I get my supposition, and I'm not able to diagnose, nor do I often care to, like has been mentioned, is that it's several times, like 3 to 4 times higher than those numbers. That would be my initial impression. I know of one study that looked at just PTSD for corrections officers, and that had it as high as 28%. And so I was just wondering if anyone...
We just finished a study looking at folks in Canadian prison systems, and the PTSD rate was almost 70%. So it really varies as a function of which prison, which jail, what the situation is. I'd like to, by the way, why do women have twice the rate of PTSD in our culture? Because, you can get the delicate flower hypothesis, You women who do childbirth live longer, all the guys are dead already and you're still around. But somehow the world is saying that you're the delicate ones, and therefore, a trauma, my HPA axis just freaked out. But there's no data for the delicate flower analysis. What it is that women have much higher risk factor for encountering traumas that are more likely to produce PTSD, which is primarily sexual trauma. So I don't know if I needed to say that, but I always want to make sure we get that for the Vietnam study, the reevaluation study, they looked at it, they found race and gender differences in PTSD rates when they controlled for experience of traumas prior to the war, and whether, for instance, black people were put on point more during the war and therefore more likely to be shot at than the white officers who were farther back. When you looked at all those variables, almost all of the PTSD differences between gender and race disappeared. So we need to see that these are not reinforcements of a subtle intellectual racism or sexism. It's around how is a culture yet again rearing its head in terms of having differential treatment of different groups of people.
I was just going to say on women in prison and PTSD, I'm not familiar with Mary Gilson's work that Susan just mentioned, but years ago, I did a story on the Framingham 8 women who were incarcerated at MCI Framingham for killing abusive partners. And I worked with this organization, this was back in 1986, called Social Justice for Women. And we then wrote a report seeking, actually this report was different, it was seeking compassionate release for women with HIV and AIDS. And at that time, the research that Social Justice for Women did came up with a figure of 98% of women at MCI Framingham were experiencing PTSD. 98%. So, just saying, that's one figure that came from somewhere.
Go ahead.
Okay, thank you. Oh, I wanted to add, and there's not a lot of data on this, and I can't give you the citation, although we did some in our local community. Another group that we haven't talked about is the LGBT community has very high rates of exposure to traumatic experiences and high levels of trauma-related symptoms associated that, what much larger than in other kind of national samples. So it's an overrepresentation of exposure to traumatic events beginning in childhood. And not nearly enough work is being done on those issues, in my humble opinion.
Hi, this was just a comment concerning the earlier comments about how with psych meds that you're not the person you were before or you're shut down. And I just wanted to mention that I've witnessed in myself as well as people that I've worked with that I think instead of numbness, there's the potential for less self-destructive agitation and incapacitating depression. And I don't feel like the real version of me is when I'm out of control. I just think that meds can help you sort of get your head above water enough to be able to learn to practice things like acceptance and mindfulness and self-compassion. And all of which I've learned in both Buddhist contexts and at a psychiatric hospital, which has been just as influential with acceptance, mindfulness, and self-compassion as any place else.
Thank you for saying that stuff. You know, I probably spoke incorrectly. What I meant to say is that you always have to see the pluses and minuses of anything. And so medications have saved many lives and clarified paths and directions for many, many people. Just as if I had certain problems, I would want meds. It's just that we treat it as some kind of panacea or official solution, and it's usually trying to fix a watch with a sledgehammer. So I'm an advocate for if you look at our book on trauma therapy, I have a whole chapter on psychopharmacology. So I so much think that you're raising these points and how personal you're willing to make it be. It's just very, very complicated. I don't know if you've seen in Tricycle, though, for instance, some mindfulness practitioners talk about the experience of taking an SSRI. They were very attuned to their internal states, and they could really monitor every little thing. And they did discover there was a trade-off. And the trade-off was that you had more ability to do certain things, but they also felt that they lost a little something, too. Probably that's all I meant. I hope it didn't sound like I was saying something bigger than that. It's just that we can treat meds like it's a widget that you put into a slot and then it will solve a problem. But my guess, especially from the way you were talking, there's much more to how you are than just what your medication was at any given moment. Thank you for saying that stuff.
Thank you to all of you for being here and for doing the truly pioneering and out-of-the-box work that you've managed to do in the last bunch of years. This has become like my new conference question that I ask everywhere I go. As a student in social work, it's amazing to me, when I first read Dr. John Breer's work and could hardly even get through every page because it's so amazing, to find out how many practitioners there are in this arena and in this community. And so my question has become, when are we going to turn the tides? I even read a recent article that was great. It was chapter 24 about risk and resilience, and it said that these terms need to be more defined, and I agreed with that. But then the author went into, there's more research that needs to be done. And so I kind of come in as we have the research. So just to pick your brains and your expertise as to when we're going to see that all the work that you've been doing becomes more predominant, because there's so many people that need it, that go into talk therapy offices and wind up coming out with a ton of medication and nothing else. And so I hope that question makes sense does it make sense what I'm asking?
Makes lots of
Yes.
sense.
Okay.
Makes total sense. Actually, since I couldn't think of a title, Conclusions and Future Directions, that's part of what I want to talk about. But I think what's fascinating is, in the culture, the tide is turning, but we still have much more work to do. So it's amazing to me the number of places you will see mindfulness talked about, including we were just talking about the other day of Mindfulness on Time magazine and how it's turning up in our cultural zeitgeist, not just in the literature, but in the therapy literature. However, I think one big barrier is funding. So I was really glad to hear that you were able to get that funding, because I think there's still a lot of mainstream science that is focused on more traditional methods. And because of that, the work doesn't get disseminated as broadly as will be useful. So I have this belief that that's going to happen, but we're still in the midst of, talk about being activists, you in the room, we're still in the midst of making this happen. And you being here and being willing to carry the message to other people, that's part of how messages change. Did that answer your question, sort of?
Most definitely. Just as a good news, the OT round came back recently, and it was the huge focus of the OT conference with thousands of people.
Yeah, I see it a little less as us, them, around this in particular. I'm as good as the next guy at objectifying others. I don't mean to say. That doesn't occur to my mind. But in this particular arena, there's a number of things. People say, well, is this going to become really part of practice? A psychotherapeutic practice in a broad way? And I don't know. It depends on how much people want to do this work themselves as clinicians, as researchers, because it's really only the folks who have found this to be personally transformative that wind up making this part and parcel of their work through and through. I mean, there's lots of folks who say, oh yeah, I teach mindfulness, but who have never made it personally very transformatively a central practice. And I'm not saying it doesn't contribute something, but I don't think it reorients the way we approach treatment. And furthermore, I think a big task that we've all got is seeing, well, how is this already going on under different names? That, my sense is many of the other, quote, traditional forms of treatment are including large swaths of what we think of as the insights and the methods and the mechanisms of action that are part of mindfulness practice, and they're just not necessarily calling it that. And part of our task is to build the bridges, do the translational work, help people to see where perhaps we have much more in common, because people are much more likely to take this up as part of their work if they see it as an extension or an enrichment of what they already know how to do than if they see it as, oh, that camp that's popular now.
I just wanted to come back to the point about the statistics for men and women in trauma. And one of the things that I kind of, I'm currently finishing up my dissertation, and I'm looking at the intersectionality between kind of normative violence and shadow economies among Latino men and how they construct masculinity within that. And so one of the things that I wanted to kind of comment, ask, bring up is how much in our research we're currently doing kind of binary categorizations of like male, female, black, Hispanic, Latino, and what we're doing about making our understanding of the context more fluid, more qualitative, more kind of nuanced, like by exploring things like masculine, machismo. Because I'm a female, but I do consider myself sometimes that I'm very machista in how I kind of behave and interact in the world. And so those are kind of the things that I was wondering about, how you approach in your practices and your research this more kind of fluid, nuanced way of looking at these, what we primarily looked at as binary constructs.
Well, yeah, what you said, yeah.
Yeah, and I think that's, you're working on your degree in social work. Well, okay. I'm ecstatic to hear that, because I hope you take that force forward. This is one of the advantages for me in working with my student who's working in this area is that it is not a binary thing, that there's a lot of variables that one needs to consider, and I think that's a key factor not to be lost in both clinical and research practice. So I'm glad you brought that up.
Yes, my question is, where do I find information, or if any of you could provide some information on what would be the best way to bring or to help young kids, especially teenagers, on learning about mindfulness and meditation, other than the school systems? I'm talking primarily within families. Thank you.
Randy Semple has written a very nice book on mindfulness treatment using MBCT, cognitive therapy, for anxiety in little ones, even pre-adolescent. We're now using her to design our mindfulness for adolescent programs. But I would recommend that book. So it's SEMPLE, and it's basically an adaptation of MBCT for kids that are like 5, 6, 7, 8, and it's focused on anxiety, but we're using it with trauma as well.
Did she have a chapter in that?
And she has a chapter in this new book that this is all about. So her and Layla Madney have a chapter in there about this. The name? Semple, SEMPLE. But then there's a couple other people. Do you guys want to?
Do you have an answer? Yeah.
Yeah, Gina Beagle has been working in California for years. I've worked with her closely. So BIEGEL. She has published material. She does courses online, and she teaches educators. And she has a wonderful group there and has done a lot of very good quantitative research to back up the work that she's doing. And kids love her. So she's a great teacher, yeah. And works through school systems across the country.
And quite locally, Chris Willard has a beautiful book, Child's Mind, about working with children. In the self-compassion area, the self-compassion training program that Kristen and I developed has been adapted for teens by Karen Bluth and Lorraine Hobbs. Their work is coming out in the next few months. Also at Richie Davidson's center in Madison, Wisconsin, they have an amazing program for 4-year-olds called Kindness Curriculum. So there's so much out there. I mean, if you just Google mindfulness in kids, right, you'll get like 100 pages probably.
So just to jump back to the kind of what's next question, I'm probably greatly understating it, but just I'm 4 years out of graduating from Leslie, and did 3 years at a large mental health clinic with sort of the belief that it could be different and we would do great things, and having kind of burned out and been sucked in. I guess just to name that there's the 2 years post-grad gap where you're not yet licensed. There's something there where, you know, I think eager clinicians who come with this rich holistic perspective are getting lost in the shuffle, and maybe that's not, you know, everywhere, but just that you know, that's sort of a thought. And funding-wise, there's a lot in the Children's Behavioral Health Initiative and through Mass Health. So there's funding and there's bodies and minds and hearts, but sort of pre-licensure resource.
Someone over there? Far corner.
Over there?
I hope this might kind of dovetail a little bit, because I feel like one of the things that I have a question about too is just about your own self-care and how to use mindfulness, especially when working with trauma survivors. I feel like the more I practice, kind of going back to what you were saying about your deer meditation, the more acutely I feel everything. And I feel a lot of anger sometimes, a lot of sadness, a lot of things, obviously, that sometimes my clients aren't able to feel in that moment. And I just was wondering if you could say a little bit about each of your own, kind of how you are using mindfulness.
That's nice. Why don't we each answer that? Yeah.
Yeah.
Do you want to start?
Just to understand your own limits too, and become self-compassionate?
Yeah, I guess meditation. I go on a fair amount of retreats, meditation retreats. In terms of self-care, I think what I did about a year ago was, it was called the Integrated Study and Practice Program at the Barry Center for Buddhist Studies. I don't know if anybody here is familiar with it, and it's actually not, it ended now. It's not happening anymore, but that's a year-long program in which a small group of people come together 4 times a year for a full week and meet with Andy Olensky, the wonderful Buddhist scholar, and a meditation Dharma teacher. So that was wonderful too. But I think the backbone of my daily practice is sitting down on the cushion every day. And if I don't, I know it. So.
Got about 5 more minutes. Do you want to say something?
Sure. I mean, I think it's really important. And for myself, on a very personal level, I just try to develop some self-compassion, recognizing that, you know, that I'll have responses. Sometimes, in peer supervision, sometimes tears come, sometimes anger comes. And recognizing that, yeah, I'm a human being, and that it's very painful sometimes to sit with and to try to connect with people who have been abused or oppressed, or, you know, have had terrible things happen to them. And daily practice, you know, I have a personal Buddhist practice, so I try to connect there. But also for myself, I just try to be a little bit lighter on myself, because a lot of times I get embarrassed or freak out that, you know, I'm having these reactions, and I think, oh, it's okay, you know, or it's not okay, but it's happening, and I'll get through it.
I love that. That's great. I would say meditation. Another thing that I think is really important for many of us is being part of a consultation/support group. I think working with other professionals where it's safe to talk about, get ideas about your work, but also talk about your own processing, as opposed to being sent home and feeling like you need to absorb all of this yourself and be really strong, and never be worn down by how hard the work is, because it is really hard. And the other thing is that it fuels my advocacy mission in terms of, yeah, and I heard John say this probably in 1989, but at some point, not just being in the room, but also outside the room, how do I want to make the world different in my own little way?
So, you know, when we talk about burnout, I mostly think that what burns us out is not our exposure to our clients, it's the institutions in which we work. So I think it's important to identify the locus of the difficulty. I actually think the work with hurt people, of which we are members of that group, is vivifying. I'm always embarrassed to say this, so I always say it everywhere. But I leave the burn unit and I lean torture consultation, other things, with a pep in my step. I feel more grounded. I feel more clear. And it's so horrible when you think about what we do for a living. Why would that make us feel this thing? But I think it's because our problem is avoidance and resistance, and the institutions that do that to us anyway, which is huge, huge. So I think that, like, when you come out of a retreat, you know, and you see I saw a chipmunk run over by a car when I was leaving a retreat. I was devastated for like 4 hours. Have you had that? It's like, because you're all tender and open and stuff. But the thing about that, just like the deer, I think is that actually our job is not to say, oh, I do hard work and it's difficult, and how do I protect myself from the adverse effects of that, but instead to join that and go, whoa, that pain, that experience, the chance to observe the roots of suffering. We're all on a bodhisattva journey in this room. We're so awesomely lucky here that we chose a thing that would allow us to get Buddhist training even if we never heard that guy's name, which is to be present with people who are suffering and not just have to do something about it. So I don't know if that works for you guys, but I just feel like if I feel really crushed by seeing some person in a really horrible situation, I'm interested in that, and I want to engage that for myself and for them. You know, and sometimes it's almost selfish that I want to stay present because I know this is where the gold is, or probably not a good metaphor. So I would say that it would be meditation, but it would also be an approach to say that the people that we work with are not the problem. The world they come from and the organizations we operate in, that's the problem. So that we know who we're for and who we're again in this dynamic.
Yeah, nowadays in the compassion fatigue field, we also talk about empathy fatigue. And that is that when other people suffer, it is real suffering. It feels like our own suffering. And really the only prerequisite for empathy fatigue or compassion fatigue is being human. But what John was talking about was really this beautiful quality which turns empathy fatigue, which allows us to have energy for this kind of work, and that is the addition of love. So when we feel a person suffering and then we turn toward with curiosity and kindness with the bodhisattva ideal, then we're actually energized by the work. The question is, how do we actually get from there to here? In other words, how do we activate this quality of loving kindness and so forth? I appreciate what Victoria said in terms of having a sangha, a community. But I think a critical element in this whole field is self-compassion. When we're suffering, can we in fact turn toward our suffering, recognize this is a moment of suffering? Can we see it as part of the human experience? And can we be kind to ourselves? And then in that way, we can nourish others. Usually with self-care, when we have compassion fatigue, we ask people, how do you care for yourself? It's always about going away. Going on vacation, seeing fewer patients, and so forth.
That's exactly right.
And what does self-compassion do? It actually allows us to be in the field and nourish ourselves in the relationship so that we can remain in connection. So a very simple technique, which I practice while doing therapy, particularly with traumatized patients, is when I notice my breathing, and with every in-breath, I breathe in for myself, and with every out-breath, I breathe out for my person. In for me, out for you. One for me, one for you. That's loving others without losing ourselves.
Yeah. I find that for me, what most tires or burns me out is my own resistance to whatever is happening, and I'm not at a state of development where I can do several psychotherapy sessions without accumulating a fair amount of unmetabolized feeling, because I'm trying to do several things simultaneously. So it's really about just having some space to be able to feel whatever came up and be with that. And sometimes it's very much facilitated by doing that with another person who's caring, and we can talk about it. Sometimes I can just do it with myself, but I find it's the John's theme and Chris's theme now and everybody else, that it's the attempt to avoid the pain that burns me out. And when I can, you'd think I'd know by now, but I don't, and when I can remind myself of that and say, no, it's about being with the experience rather than trying to get rid of it, almost invariably, some painful thing comes up, and it doesn't last forever. It comes and it passes, and then I'm okay, and then I'm more fresh to meet whatever the next moment is.
And now a word from our sponsor.
So, it's 12:15. My stomach is grumbling. I'm sure yours is too. Before we end, we've been given a special gift. We're talking here in the last few minutes about self-compassion and compassion and what we do to feel resourced. Before we came back from the break, I was approached by one of our friends here in the audience with a gift. So this is the gift of generosity in service of our well-being. She's offered to sing for us. Mm-hmm.
So for me, music is sort of like lighting a candle. So this is sort of like an oral candle. This song has been floating around in my mind, and I wanted to float it into the room, and the only way to do that is to sing it. I heard it in 1979 on a Paul Winter album. I've never sung it before. Now you can be as nervous as I am. We all hope this goes well. But I offer this as an invitation for it to float in your mind and your heart. And you are also invited to close your eyes, and you're invited not to clap at the end if that feels right to you. And it will certainly feel right to me. Lay down your burdens, oh, lay 'em all down. Pass the glass between you, drink it up. Place the light before you, come through the door. The dragon doesn't live here anymore. Sing with the choirs that surround you and dance to the music in your soul. Look into the eyes that really see you. Place all that you have into that bowl. Oh, lay down your burdens. Oh, lay 'em all down. Pass the glass between you. Drink it up. Place the light before you. Come through the door. The dragon doesn't live here anymore.
You have to clap.
Couldn't restrain.
So I forgot to mention your name, Audrey Perkins.